I'm going to try to cover parts 3 and 4 in here, as well as touch on developmental. I think we can get through that in a reasonably short video. So let's start with motor endings and motor activity. Peripheral motor endings. Motor endings in the peripheral nervous system activate an effector released by releasing a neurotransmitter. So we've talked a lot about activation of skeletal muscle. We haven't talked as much about smooth muscle in the visceral, and we've touched on glands. So remember, motor, people think movement, and that's true in skeletal and visceral muscle. But other than the gland itself moving, it's the release of materials from the gland that is an output here. So in skeletal muscle, it takes place at the neuromuscular junction. We spent a lot of time looking at that when we looked at the muscles. The neurotransmitter is always acetylcholine. It's released when the nerve impulse reaches the axon terminal. Then acetylcholine is released from the axon terminal, binds to receptors that cause sodium and potassium to move across the membrane, depolarizing the muscle cell. That starts as an end plate potential. It can spread to adjacent areas of the sacrolemma. That would start the opening of sodium voltage gated channels, and that results in an action potential that moves down the muscle fiber. That leads to muscle contraction. We've seen this before. Visceral muscle and glands. We have autonomic motor endings and visceral effectors that are simpler than that somatic junction. They branch and form synapse en passant, or synapse in passing, with effector cells through structures known as varicosities. And we have acetylcholine again as a neurotransmitter, but we also have norepinephrine as a neurotransmitter here, and they are going to act through second messenger systems. That means that the visceral motor response is going to be slower than the somatic response. So these are the structures that are known as varicosities, and from these varicosities in smooth muscles, they will release the neurotransmitters, epinephrine or acetylcholine, and that will cause the smooth muscle to contract or relax in some cases. So the cerebellum and the basal nuclei are the ultimate planners of coordinating and coordinators of complex motor activities. And to do that, they use 3 different patterns of controls. There's control at the segmental level, the projection level, and the pre-command level. So the pre-command level is the highest. It's where the cerebellum and the basal nuclei come into play. They program the instructions, send that to the projection level, where the motor cortex, which would include the pyramidal pathways in the brainstem, the reticular formation, take those instructions and send them to the spinal cord motor neurons, and that would send they would also send a copy back up to higher levels, and the instructions from there would make it to the segmental level, which would include the spinal cord, sending information to the specific skeletal muscles to do their function. So the segmental level is the lowest level of motor hierarchy. It's the reflexes and automatic movements that occur. Segmental circuits are going to activate networks of the ventral horn neurons to stimulate specific groups of muscles. And we have things called central pattern generators, which are circuits that control locomotion at specific, often repeated motor activities. So they consist of networks of oscillating inhibitory and excitatory neurons that set a crude rhythm and pattern of movement, similar to what we thought was going on with respiration control. At the projection level, we have upper motor neurons that initiate direct system to produce voluntary skeletal movements, and that is pyramidal. And then brainstem motor areas that oversee indirect systems to control reflex and central pattern generated control movement actions, and these are extrapyramidal. The projection motor pathways send information to lower motor neurons, keep the higher command cell level informed of what it's doing. So the pre-command level is the neurons in the cerebellum and basal nuclei. They are going to regulate motor activity, precisely start or stop movements, coordinate the movements with posture, block unwanted movements, monitor muscle tone, and perform unconscious planning and discharge in advance of willed movements. Cerebellum acts on motor pathways through projection areas of the brainstem, and it acts on the motor cortex through the thalamus, which fine-tunes motor activity. And the basal nuclei inhibit various motor centers under resting conditions. You should think back to Parkinson's disease, where you have resting tremors, and that's injury to the basal nuclei or an issue in the basal nuclei. So let's talk about reflexes. Reflexes are important because many of them are small circuits in the nervous system without much redundancy. So when we're talking about most things in the nervous system, there is a lot of redundancy, a lot of overlap. So it would be difficult to detect some problems early if we were looking at complex functions. But when we look at simple reflex circuits, we are more likely to pick up issues quicker. So there are a couple different types of reflexes. There are inborn intrinsic reflexes, which are rapid, involuntary, predictable motor responses to stimulus, maintaining posture, controlling visceral activities. They can be modified by learning and with conscious effort. And then we also have acquired reflexes or learned reflexes that result from practice or repetition. So if you have driving skills, you had to learn those driving skills. For any reflex arc, there are some components, 5 components we're going to break it down to. A receptor, sensory neuron, integration center, motor neuron, and effector. The receptor is where the stimulus occurs. The sensory neuron transmits that information to the central nervous system. In the central nervous system is an integration center. That can be either monosynaptic or polysynaptic. It can be in the spinal cord or include the brain. From there, it goes to the instructions go to a motor neuron, which conducts efferent impulses to from the integration center to the effector organ, and the effector is either a muscle fiber, skeletal or smooth, or a gland that responds to the impulse by contracting or secreting, depending on what it is, muscle or gland. So somatic reflexes activate skeletal muscles. Autonomic reflexes activate visceral effectors, such as smooth or cardiac muscle or gland. So we have a receptor, which passes that information to a sensory neuron. That sensory neuron talks to an interneuron, which will be the integration center. And in the case of this reflex, that neuron passes the information to a motor neuron, which causes the muscle to contract. And that's a simple 3-chain pathway with one interneuron, a sensory neuron, and a motor neuron. But just because we draw it out this way, this interneuron, this sensory information, and even this motor neuron, these are not the only connections between them. It's also passing the information upward. So spinal reflexes occur without the direct involvement of higher centers. The brain is still aware of it, advised of it, knows what's going on. They get the information, but they don't have to process the information to get an effect. And testing of the somatic reflexes is important clinically, as I said at the beginning, because it helps assess the condition of the nervous system. If there's a problem in the conduction, some kind of pathology going on, you're going to see it in these simple circuits faster than you would see it in complex structured circuits. So the ones most commonly assessed are the stretch, flexure, and superficial reflexes. To smoothly coordinate skeletal muscles, the nervous system has to receive proprietary input that lets it know about the length of the muscle. That comes from muscle spindles and the amount of tension in the muscle, and that information comes from the tendon organs we spoke of. The muscle spindles are composed of 3 to 10 modified skeletal muscle fibers called intrafusal muscle fibers that are enclosed in connective tissue capsule. So they're not really muscles, they're kind of more like a nerve, but they're built like a muscle. They have a region of interfusal fibers that lack myofilaments and are non-contractile. Each region does contain actin and myosin filaments that can contract, the end region, and the regular effector fibers of the muscle are referred to as extrafusal muscle fibers. So when we talked about muscle fibers, we were talking about extrafusal muscle fibers. Two types of afferent endings in the muscle spindle send sensory inputs to the central nervous system. They're the annual spiral endings, which are the primary sensory endings. Their endings wrap around a spindle. They're stimulated by rate and degree of stretch. And then there are flower spray endings, the secondary sensory endings, which are small axons at the spindle ends, and they are stimulated by the degree of stretch only. Contractile regions of the spindle are innervated by gamma efferent fibers, and they help to maintain spindle sensitivity. The extrafusal fibers, the contractile muscle fibers, are innervated by alpha efferent fibers and large alpha motor neurons. Muscle spindles are stretched and excited in two ways. External stretch is the external force that lengthens the entire muscle, and internal stretch are the gamma motor neurons stimulating the spindle ends to contract and thereby stretching the spindle. And stretching results in an increased rate of impulses to the spinal cord. So the more that is stretched, the more impulses are going to the spinal cord. Contracting the muscle reduces tension on the muscle spindle and sensitivity would be lost. To avoid that, the muscle spindles are also shortening from impulses by gamma motor neurons that fire when the alpha neurons fire. So alpha gamma coactivation helps to maintain tension and sensitivity of the spindle during the contraction of the muscle. Stretch reflex. The brain sets the muscle's length through a stretch reflex. A good example of this is the knee-jerk reflex, in which the stretch reflex that keeps the knees from buckling when you stand up straight. The stretch reflexes maintain muscle tone in large postural muscles and adjust it reflexively. They cause a muscle contraction on the side of the spine in response to an increased muscle strength on the other side of the spine. So the stretch activates the muscle spindle. Sensory neurons synapse with alpha motor neurons in the spinal cord. The alpha motor neurons cause extrafusal muscles of the stretched muscle to contract. We get reciprocal inhibition. Afferent fibers synapse with the interneurons that inhibit alpha motor neurons on the antagonistic muscles of that movement. So a good example of this is the patella reflex or the knee-jerk reflex, in which the stretched muscle, which would be the quadricep, contracts and the antagonist, the hamstring, relaxes. Stretch reflexes are monosynaptic and ipsilateral. They're motor activity is on the same side. Positive reflex reactions provide two pieces of info. When they're tested, it proves that sensory and motor connections between the muscle and the spinal cord are intact, and it also gives you an idea of the strength of response to the degree that the spinal cord is excitable. Clinical reflexes can be hypoactive or absent if peripheral nerve damage or ventral horn injury has occurred. Reflexes are absent in people with can be absent in people with chronic diabetes mellitus, neurosyphilis, or during a coma. Stretch reflexes can be hyperactive if there's a lesion of the cortical spinal tract that reduces the inhibitory effect of the brain on the spinal cord. So when a muscle stretches activated spindle, the sensory neurons transmit afferent impulses to the higher frequency to the spinal cord. The sensory neurons synapse directly with alpha motor neurons, which send signals to the target cell, and that target cell causes the efferent muscles to contract and relaxes the ones on the other side of the joint. Shown here with the knee jerk reaction, or the patella reflex. When gamma neurons are stimulated by the brain, the spindle is stretched, contraction force is maintained or increased. If the gamma neurons are inhibited, spindles become non-responsive and the muscle relaxes. It's important as speed and difficulty increase, so a gymnast on a balance beam needs to practice this a lot. A tendon reflex involves polysynaptic reflexes, helps prevent damage due to excessive stretch. It's important for the smooth onset and termination of muscle contractions. Produces muscle relaxation, which is a lengthening in response to tension. Contraction or passive stretch activates the tendon reflex. The afferent impulses are transmitted to the spinal cord. The contracting muscle will relax. The antagonistic muscle will contract. This is reciprocal activation. And that information is also transmitted to the cerebellum so that the muscle tension may be adjusted. So here is a tendon reflex mapped out. A flexor reflex or withdrawal reflex would be initiated by a painful stimulus which would cause the automatic withdrawal of the threatened body part. It is ipsilateral and polysynaptic. There are many different muscles that are called into play, so it's polysynaptic. It's protective and important to survival. However, we can consciously override withdrawal reflexes. If you have diabetes and you need to stick your finger for blood, you can avoid you can teach yourself to avoid the tendency to pull your finger away before the needle hits it. We also have crossed extensor reflexes, and that is when the flexor reflexes in a weight-bearing limb are used to maintain balance. This is going to be an ipsilateral withdrawal reflex and a contralateral extensor reflex. You stimulate the side that's withdrawn, which would be flexed, and the contralateral side would be extended. So stepping on a piece of broken glass with a bare foot would cause the damaged leg to withdraw and the opposing leg to extend to support the shifting weight. Someone tries to grab your arm. With that arm, you would pull away, and the other arm you would extend. Superficial reflexes are elicited by gentle cutaneous stimulation of an area. There are some clinically important reflex signals that occur in upper motor pathways at the cord level, arcs, and the two best known ones are the plantar reflex and the abdominal reflex. In the plantar reflex, you'll get information about the integrity of the spinal cord from L4 to S2. The stimulus you would apply would be a lateral stroke of the lateral aspect of the sole of the foot, and you should see a downward flexion of the toes. If you do not see a downward flexion of the toes, you would have what is known as Babinski's sign, in which the hallux, the big toe, dorsiflex, and the smaller toes fan laterally. Now, Babinski's sign is abnormal in anyone over the age of 3 or so, but it is normal up until the age of 1 because until that time, the fibers are not myelinated, so they don't respond the same way. So Babinski's sign is expected in someone less than a year old. It's abnormal in adults. Abdominal reflexes are going to test the integrity of the cord T8 through 12. Stroking the skin of the lateral abdomen above, below, or to the side of the umbilicus should lead to contraction of the abdominal muscles and the movement of the umbilicus towards the stimulus. This will vary in intensity from one person to another, but if there are cortical spinal tract lesions, you will lose this reflex. Primary motor cortex and the cortical spinal tract are damaged. The plantar reflex is replaced by the abnormal reflex called Babinski's sign, which again, great toe dorsiflexes, smaller toes fan laterally. And again, infants exhibit the Babinski sign until they're about a year old because of myelination. Although clinically relevant, the physiological mechanism of Babinski's sign is not clearly understood. All right, so wrapping it up, developmentally, spinal nerves branch from the developing spinal cord and neural crest cells. They exit between forming vertebrae, supplying both motor and sensory fibers to developing muscles, help direct their maturation. The cranial nerves innervate the muscles of the head. Distribution and growth of spinal nerves correlates with the segmented body plan. As we age, sensory receptors atrophy, muscle tone decreases, particularly in the face and neck. Reflex is slow. We have decreased number of synapses per neuron, and that means slower central processing. Our peripheral nerves are viable throughout our life unless they are damaged by trauma or disease. And that wraps up the nervous system.